My name is Alejandro Calvo. I'm a medical oncologist. I'm board certified in medical oncology, hematology, and hospice and palliative care. I'm an associate professor of medicine at the Bunshoft School of Medicine in Wright State University, and I practice community oncology at Kettering Cancer Center in Dayton, Ohio. DetermaRx is a very interesting genomic assay. It looks at 14 genes in the cancer cells, and that provides a risk for recurrence that can be low risk or high risk. And that's a very important piece of information to take into account when making decisions about the need for additional treatments after lung cancer surgery. The main factor that led me to use DetermaRx in the care of my patients with lung cancer is that too many patients with early stage resected non-small cell lung cancer will eventually relapse and die from metastatic lung cancer. So we need a better way to risk stratify that group of patients. DetermaRx actually allows us to identify which patients will benefit from adjuvant chemotherapy to lower the risk of relapse. In medical oncology, data is very important, especially reliable data. So the prospective validation of DetermaRx gives me confidence to use chemotherapy in the subset of patients that needs it. And it allows the patients also to feel more confident taking some risks by knowing the benefit they obtain. In the most recent prospective validation, they took into account the EGFR mutation status of lung cancer patients, status post resection, and they found that the benefit of adjuvant chemotherapy was present regardless of EGFR mutation status. So that means that if a patient with high risk DetermaRx is seen for adjuvant purposes, you can offer 4 cycles of chemotherapy followed by TKI. I've been using DetermaRx since the summer 2020, as soon as I learned it was available for clinical practice. The integration of DetermaRx in our practice was very easy. It's a form that you fill out with patient information, you send to Oncosite in California, and they do the rest of the work. You get the results in 10 days. I recently saw a 50-year-old female former smoker diagnosed with a 3.5 centimeter well-differentiated adenocarcinoma with visceral pleural involvement. And the DetermaRx was key in making a decision to proceed with adjuvant chemotherapy because in her case, contrary to what I expected, it came back high risk. I do review the DetermaRx result with my patients. It's very interesting how they look at the report and they look at the statistics, and showing the significant benefit in the high-risk group makes them more confident in making a decision to take adjuvant chemotherapy. I tell other oncology colleagues that we use genomic assays in other malignancies, for example, breast cancer, routinely. So I don't see a reason why a proven genomic assay like DetermaRx shouldn't be used in lung cancer care. I think DetermaRx is practice-changing. With the available information, as a medical oncologist or as a thoracic surgeon, you would have to explain why you didn't do that test when you're taking care of a patient with early-stage resected lung cancer. In the future, I would like to see DetermaRx implemented in all resected lung cancer patients, early stage, or at least to have a reflex testing available so when you see the patient, the result is available to you to make your treatment decisions.